Welcome, colleagues. I see you're coming in, so please keep joining and just give us a few minutes. We'll be with you. And as you join, please note that there is an interpretation button down there. You can choose either English or French. We'll use those two languages. The webinar is bilingual, so you can choose under that icon there. We are hoping to start in 2 to 3 minutes.
And for those who might be having trouble, the icon's the one right next to the share screen icon. At least on my computer, that's what it shows. So it should be fairly straightforward. If you click on that, you can then choose the language, your language of choice.
Okay, that's an interesting one, Edwin, because mine is in between show captions and more.
C'est entre les captions.
Mine is between share screen and reactions. So I don't know who's on the older, who hasn't updated their Zoom.
Alors,
going by age, I think it's me.
Pas si vous avez, vous
oh,
devez
welcome,
avoir
Fatima.
une mise
Thank
à
you,
jour de
Doc, for joining us.
votre
We are really happy
interface.
Thank you.
Mais de toutes les façons, ça dépend de l'ordinateur que vous utilisez.
Yes. And yeah, please continue letting us know where you're coming from. I see, you know, welcome,
Isaac. Continuez à nous signaler vos pays d'origine.
Sorry, Dr. G.
Pour que je sache comment vous aider.
I'm hearing the interpretation.
J'entends l'interprétation. Est-ce que votre canal marche bien?
It's best to mute the original audio.
De bloquer l'audio
and then mute the
original.
original audio so you don't hear both.
Pour qu'on puisse pas entendre les deux.
Fantastic. So anybody who hasn't done that, I hope you can do that. So
alors,
put in, you know, pick the language of choice, and then there is right at the bottom there's something that says mute or unmute original audio, which then will allow you to have just one clean audio that you hear.
Bloquer ou ne pas bloquer,
and
donc
Dr. Fatma
la
Saleh
voix.
We're really glad
Dr.
panel is full.
Le docteur Saleh est là, donc ne vous en faites pas. Très bien.
Good colleagues, 2 more minutes and then we start and we kick off. So we'll then take the time to request the panelists to get on video. We are going to start
Alors,
in 2 minutes.
On va demander nos collègues pour se mettre sur l'écran et 32 minutes, nous allons commencer.
Thanks, Andrew, for the guidance on the audio. Thanks, Andrew, for joining.
My mistakes are the lessons for others, Andrew. So glad glad that works.
All right.
Fantastic. Should we do just a quick intro of the African Dialogues, Dr. G, given we haven't done this in a couple of months, so people might have forgotten who we are and where we're here before we start on the fun conversation?
Go with it, Edwin, and then I'll come back.
Allez-y, Edwin, et puis je reviendrai.
So for those who haven't been here recently, good morning, good afternoon, good evening, whatever you're dialing in from. My name is Edwin Macharia. I'm co-founder of AXOM, which is an Afrocentric advisory implementation and investment firm. We have 12 offices across Africa and 1 in the Middle East, and really trying to put Africa's knowledge, wisdom, and capabilities at the center of solving Africa's problems. We, Dr. G and I, have been co-hosts of the African Dialogues webinar. Really began in the height of COVID and was an important discussion area to really share what was being learned and how countries were responding and how individuals were responding and institutions were responding to COVID. But there was clear need for this conversation to continue. So it's a great pleasure to have you all back here for the Africa Dialogues. I think most of us are looking forward to the holidays. So this is a good conversation to put a pin for the year and have that important discussion about meningitis. Et nous allons avoir cette édition importante sur la méningite. Alors, Dr. J va commencer pendant que nos panélistes vont revenir aux vidéos pour que nous puissions commencer.
So I'll go straight to the overview,
Alors, je vais
and then
commencer,
so welcome everybody. I think
une vue
we've topped
panoramique. Bienvenue à tout le monde. Nous allons
80
parler
participants, and they're still coming.
de 80
So we'll go ahead. We
participants
have
et
only 1
continuons à
hour,
nous
so
rejoindre.
this is
Nous
going
allons
to be
continuer. Il
rapid
nous
fire
reste
kind of
1
thing.
heure seulement,
But
donc
I
on va
can
faire
promise
très
you,
rapide.
all of you who've
Mais
joined,
je
that we
veux
have a
vous
fantastic
promettre que nous aurons une
lineup of
séance
speakers.
fantastique
Some of them speaking
et
to
nous
us
aurons un
as
groupe et un
keynotes and
panéliste, un groupe de panélistes
overviews, and others
importants.
speaking to us on the panels. And at the end, we will have an
Et à la
opportunity
fin,
for
on
you to
aura
ask
une
questions or make
occasion
comments.
pour que vous posiez des questions ou des
I will handle the first
commentaires.
session, and my
Et je vais
co-host
passer
Edwin
la
will handle the
première
panel,
séance à mon
and then we'll together handle the questions depending on how they come in.
pour la
But
présentation.
as Edwin has said, the Africa
Mais
Dialogues has
comme
remained a
Edwin
platform where
l'a
we
dit, le
discuss
dialogue
critical health
africain est
matters
une plateforme où
relating
nous
to our continent
discutons
in
des
Africa.
questions
And we
pertinentes
bring
pour
together
la santé en
experts
Afrique
in
et nous
various
amenons
areas,
des
either
experts
technical
de
policy
différents
experts,
domaines, que ce soit
community implementation
au niveau
experts, private
politique,
sector experts,
des
or whoever
experts
is needed in that
communautaires,
space
tout
to
ce
address
dont
the
nous avons
issue.
besoin dans cet
The
espace
issue
pour
we are
répondre
addressing
aux
today
questions.
is
La question que nous
meningitis.
voulons tacler,
And the
c'est la
reason for this
méningite.
is
Et la raison pour
because if
ceci,
you look, tomorrow is actually
vous
the
essayez de
Universal Health
regarder.
Coverage Day,
Demain,
International
c'est
Day
la
for
journée de la
2024.
couverture
And
internationale
tomorrow's theme for the
mondiale et
International
le thème de
UHC
demain
Day is
cette
that
journée,
government's
c'est que
health
les
is
gouvernements,
by
dans
government.
le
It's
gouvernement,
basically saying that health is
les
on government,
gouvernements
meaning that
gèrent
the
la santé.
government
Donc la santé,
that
c'est-à-dire
has
les
any
gouvernements
particular
qui ont
disease, outbreak,
une
or
maladie
health concerns,
particulière,
it's the
une
responsibility of the
pandémie.
government to
C'est
coordinate,
la
to create the policy
responsabilité du
framework, and to
gouvernement de
ensure that
coordonner le
people have
travail
access to the
et pour
services
s'assurer
they
que les
need
personnes ont
without
accès aux
financial
services dont
difficulty. So
ils
there
ont
are many
besoin
layers there
sans problème
around
financier.
what
Donc, il y a beaucoup de
profiles of
domaines
diseases are
autour
there,
de différents
what kind of
profils,
access,
quel type d'accès,
opportunities or challenges exist, how
opportunités
far
ou
people
défis qui
are
sont
from health
là,
facilities,
comment est-ce que les
how much
personnes
health
sont
workforce is available,
et
availability of
quelles
preventative
sont
commodities
la
like vaccines, curative
disponibilité de
commodities,
vaccins,
bed
de
space, all the things
médicaments
that people need,
curatifs,
and community
tout
health
ce dont les
systems,
personnes
really,
ont
and
besoin.
also an
Et les
enabling
systèmes
environment to keep
communautaires
away
qui sont là,
disease.
mais aussi un
So when you
environnement
look at that
propice
holistically
pour gérer
as
la
a
maladie.
UHC
Donc, si on
agenda,
regarde
then
toute
this
cette
particular UHC agenda
architecture,
is on the government. Of course, not the
et
government
ça,
alone,
c'est
supported
le
by
gouvernement qui
civil
doit le faire.
society,
Bien sûr, le
private
gouvernement le
sector,
doit
and
faire,
everyone else coming
appuyé
together.
par le
But the
secteur
government is the
privé, la
driver
société
of the
civile et
bus.
les autres, mais
And
le
therefore,
gouvernement
when you look
devient
at this,
le
you start to
responsable
ask,
principal.
what
Mais si
is
vous
it that government
regardez
need to do to
à ce
address the
dispositif,
health
on se
challenges
demande
of
qu'est-ce que
their
le
people?
gouvernement doit
They
faire
need to
pour
achieve
répondre à ces
universal health
défis.
coverage. That
Leur
is really
peuple,
it.
par
And remember
exemple,
that
c'est
that
d'abord
is the key message
à
for tomorrow.
réduire la
But at
couverture
the same time, as
universelle.
Amref Health
Et en
Africa,
même
we've been
temps,
looking at health
comme
across the
Amref
continent.
Afrique, nous
And we've
allons
actually said
voir à
that
travers le
as we
continent
achieve universal
comment
health coverage,
nous
needs to be
pouvons
achieved within a primary
aider,
healthcare
comment
context,
est-ce qu'on doit
where
le
the first
faire,
contact is the best
parce que
contact. Meaning
le
that when
premier
people,
contact,
wherever
c'est
they
le tout
live,
premier contact.
when they need
C'est-à-dire que
health
les
services,
personnes doivent
whether they're
avoir les
advisory,
services
preventative,
là
or
où ils
curative,
vivent,
or
que ce soit
rehabilitative, or
des,
otherwise, they
des
find them near where they
curatifs,
live, where they play, and they're
réhabilitatifs
actually
ou autres.
responsive to their
Il
needs.
faut que
But then we
les
also know that
gouvernements
there's a
répondent
lot
à
of
leurs besoins.
disruption
Nous
that's
savons
happening,
aussi
which
qu'il
is
y a
the
beaucoup
social determinants and
des
ecological determinants.
problèmes, il
We
y a
know there is
beaucoup de
climate
déterminants
disruption,
sociaux
we know that there is
qui vont causer
urbanization, there
ces
is
problèmes. Il faut
conflict,
voir
there
l'urbanisation, il
is
y a des
changing
conflits,
demographic, all these things
il y
then
a le
frame
changement
the
dans
social and ecological
les segments
determinants
démographiques.
around
Donc,
the
il y a ces
achievement
variables
of
ou
UHC around
ces
primary healthcare.
variables, ces
So when you look at
déterminants
meningitis, which is our
socio-économiques qui
conversation
sont là.
today, it
Quand vous
is
regardez
actually the
alors
best
la
example
méningite,
of
c'est un
how
bon
UHC works or
exemple de
fails and
comment
how social determinants actually
les déterminants
interrupt the access of services. Because we know that in the meningitis belt, which is largely the whole line between Senegal and Ethiopia across the continent of Africa, we know that part of what is driving the recurrent outbreaks there, whereas we have made good progress, what's driving this is basically instability, conflict, but of course, access to services, lack of early diagnosis. So it becomes a very good case to discuss to see what is it we can do to resolve UHC challenges, to resolve also those on how do we work around these social determinants ahead of our Africa Health Agenda International Conference in March, which is going to be held 2nd to 5th of March in Kigali, Rwanda, whose theme is social and ecological determinants of health. So we put together experts around this area to set the stage for our conversation on
Et donc,
actually
ceci
having
doit
a meningitis-free
lancer
continent, making
vraiment
sure
ce
we have
débat
a
sur comment on peut gérer la
meningitis-free Africa.
méningite sur le
So,
continent
to start us
africain.
off, we are going to ask Dr. Seth Buckley. Seth, as many of you
Alors, on
know,
va
was the
demander le
CEO of
docteur.
Gavi, the Vaccine Alliance, for a long time. He is a scientist of note,
Il est
globally recognized and respected, and
vraiment
Seth is going to
docteur
give
respecté
us kind of a
mondialement
stage setting on what we need to
et
pay attention to, why this is important,
va nous donner des
and his
idées sur
recommendations.
les
Then we'll
éléments auxquels
get
nous
to
devons payer
Beth Evans,
attention,
who works with the
mais
Global Vaccine
aussi
Alliance, to say what is Gavi doing programmatically around this area and what are countries doing and what do we need to respond to. And finally, we move to panelists who are country,
puis nous allons passer
focused
aux
on what
panélistes
exactly
qui
countries
sont,
are doing.
qui ciblent
And
les
that will
pays
be taken over
pour
by
voir ce que
Edwin.
les
So,
pays sont en train
Seth,
de faire.
take it away for your 5 minutes.
So,
Alors
Gitinji,
là,
thank you.
vous avez
And
l'antenne
I
pour
think
5 minutes.
I've got some slides that the team is going
Je
to put
crois
up.
que j'ai quelques
But
diapos
just
que
to
je vais
start,
vous
I think
présenter.
the critical thing to say, next slide,
Je
please,
pense que l'élément
is
principal qu'il faut
that
mentionner,
Africa
c'est
is
que
bearing the brunt
l'Afrique
of what we're calling bacterial
prend vraiment
meningitis, and that's
le
important.
gros lot
Meningitis
de la
exists around
crise
the
de la
world. It can be parasitic, it can be
méningite.
viral, but
Ça peut être
Africa bears the
viral, ça
brunt,
peut
and
être
you've
autre
already
chose, mais
mentioned,
l'Afrique
Gitinji,
gère
the
le plus gros
meningitis belt,
lot des
26
cas
countries. You can
de
see here in
méningite
red
et les
across the
26 pays les plus
continent.
affectés sont en
And
Afrique à
this
travers
was
tout
a
le continent.
long-standing
Et
problem,
ça, c'était
mostly
un
caused by
problème
meningococcal A. And it's important
causé
to say
par
that there are
donc
12 different strains of
le
meningococcal
virus
disease. 6
du
of them can
méningite.
cause epidemics, and we'll
Et
come
nous
back to
savons que
that. Next
6 de
slide,
ces
please.
virus du méningite peuvent causer une pandémie.
So WHO has recently put
Alors,
together a defeating
l'OMS a mis
meningitis program,
ensemble
and the
un
idea is
programme
to
de
eliminate bacterial
défaire
meningitis
la
epidemics
méningite
and reduce
et
the number of cases by 50%, deaths by
pour réduire donc
70%,
le
and
nombre
importantly,
de
reduce
cas
disability and
et
improve the quality of life
réduire
after it.
vraiment,
Because
et donc
if you
améliorer la
recover
qualité de la
from
santé en
meningitis,
Afrique,
you may have
parce que quand
deafness,
vous
you may
guérissez
have
du méningite,
problems
vous pouvez
with your
avoir certains
neuromuscular system.
problèmes
And so we're
avec
going to talk
votre
mostly
système
about
musculaire et
epidemic
autres, et nous
and
allons parler
prevention,
donc
control, and diagnosis and treatment,
de la
but good surveillance,
prévention et du
advocacy
traitement de
on
la
this, and
méningite,
support
mais
for the
aussi
people are
de la
all critical parts of
surveillance
that. Next slide, please.
et de la surveillance de ce problème. Diapo suivant.
Now, when this discussion was had, this is just
Quand
really
cette
important. This
conversation a
was the
commencé,
first time a group
c'était
came
la
together and
première
said,
fois un
we're going to
groupe est venu
solve a
ensemble et s'est
vaccine
dit,
for
nous
Africa.
allons
And the
donner
critical
les
issue was to
vaccins pour
get a
l'Afrique.
vaccine
Et la
specific
question
for
pratique
meningitis
était de
A,
savoir
and to
comment
get it
pouvoir
really
amener ces
inexpensive,
vaccins dans ces
around 50
communautés.
cents a
Parce que
dose.
c'était
And
très,
lots
très
of people
cher
came
avec
together. The
toutes les
single
doses qu'il
most
fallait
important thing on
déposer.
this slide,
Alors,
though, is the
l'élément
26
important sur ce
countries
diapo,
that
ce
worked
sont les
really
pays
hard
qui
to
ont
both
travaillé
understand the problem
hardiment
and then
pour comprendre
obviously
le
get
problème et
involved in the
évidemment
implementation. And
être
so
impliqué
the
dans la
Serum
mise
Institute
en
of India
œuvre.
made this
Et donc,
vaccine along with PATH, and the Gates
l'Inde,
Foundation financed it, and all of
une
a sudden we
entreprise
had a
de
tool that
l'Inde
was
a
affordable
fabriqué
that could be
le
used
vaccin
both to
et
deal with
ça
epidemics,
peut être
but also
utilisé
to
pour gérer les
put into
épidémies,
the routine system, which I'm sure Beth will talk about in a minute. Next slide, please.
mais aussi
Now, this is looking at why this was so
alors,
important.
Ici, on se dit pourquoi c'est
Historically,
important.
these epidemics would occur every 5 to 12 years, and they were devastating. They would
5 et
stop
12
countries
ans
dead
et
because of
ils ont
all of the people who were
vraiment, ils
sick. It
étaient
was terrifying. You'd end
dévastateurs
up with all of
et
the deaths,
c'était
but also
terrible.
the
Il y avait
sequelae.
beaucoup de
And you can
morts, mais
see up
aussi,
and down, up
comme
and
vous
down,
pouvez
up
le
and down.
voir,
Not
il y
totally
avait
understood
cette courbe
why,
qui montait,
but you can
descendait,
see
on ne
this
comprenait
tail
pas
that I've
pourquoi.
actually
Vous
drawn
pouvez
out
voir qu'il y
because
a cette
after
queue
this
qui est
vaccine was rolled
maintenant
out,
qui est en bas, et quand on
meningococcal
a
A
lancé le
has
vaccin,
virtually
la
disappeared
la
from these
méningite,
countries.
le
That is an
méningocoque
extraordinary thing
a perdu
and
donc de la
something we
force.
have to celebrate.
Et
And this is an
c'est
African
quelque chose que nous devons
success that's
célébrer
incredibly
comme
important.
un succès
Next slide.
africain. Diapo suivant.
This is a little bit complicated, but
C'est un
the
peu
red
compliqué,
is
mais
similar
le
to the
rouge
previous slide showing
est
after the
semblable
vaccination
au
in the
premier
dashed line, you
diapo.
can see
Vous
meningitis
pouvez
A
voir
disappearing. But
la
what's
méningite
important is
A
you see the
disparaissant,
non-A
mais ce
meningitis
qui est
continuing.
bizarre, c'est que
And
vous
in fact,
voyez
there's some evidence in this
une autre
particular
souche de
set
la
of studies
méningite qui
showing
continue
perhaps
à
some
monter.
increase
Il
in
y a
this.
des études
This is the challenge that
ont
we have to deal
démontré
with.
qu'il y
Next
avait
slide.
cette montée de cet autre type de méningite Et donc, on
In
peut pas
terms
se
of
dire
countries have
alors,
done a
en
good
termes
job
de
getting the
pays
vaccine out,
qui ont fait un
affecting
bon
it.
boulot
You can
pour
see that
avoir
virtually in
les
every country
vaccins,
in the meningitis belt, there has been a reduction in meningitis incidence, but there still is
mais
meningitis. It is
il y
still a
a
problem. It is still a challenge. And that's why
c'est
we need
toujours
to
un
continue to
défi dans
work
ce
on
pays,
this.
c'est pourquoi nous devons
And then
continuer à
last
travailler.
slide,
Et puis
please.
la méningite est le dernier diapo.
So this is the important
Alors,
slide, the
ici,
take-home
c'est
message here.
le
This is
diapo
the different
important que nous
types
devons rentrer avec ça.
meningitis. Type B is not in the vaccine, but you see we're not seeing a lot
qui
of
n'a pas
type
de
B here.
vaccin.
Type
Mais
B
vous
is
ne
a
voyez que nous
strain that's
n'avons pas
seen in
beaucoup de cas
college
de
kids and other
type
things and
B
in other
qui
outbreaks.
attaque surtout
But we
les
go from the
enfants
blue, which is the meningitis A,
et la
before we
partie
had the
bleue
vaccine,
qui est la
to seeing
méningite
that
A
completely
avant
disappear.
d'avoir le
And
vaccin.
now we're seeing outbreaks of
Il y avait
meningitis C
et maintenant nous
and
voyons
meningitis
la
W, as well as some X and others. So there is a new vaccine now
qui
that
vraiment
WHO
sévit
has
et
pre-qualified and has been
l'OMS
recommended
a
for this. Nigeria was the first to use it, and I'm sure we'll
le
hear about
Nigeria parce
that
que
from
était
our
d'abord
Nigerian
le premier pays à
colleagues.
utiliser
And
le
so
vaccin.
this is an opportunity
Et
to
ça, c'est
shift
une
from just
occasion
meningitis A
pour
to meningitis
quitter de
vaccines
la
that cover the full
méningite
range of
A
strains
pour les
and can
vaccins
reduce the disease burden and
qui sont
hopefully
capables de réduire
eliminate
donc
this as
les
a
infections
problem
ou
across
même
the continent.
éliminer la
I'll
méningite
be
comme le
around during
problème
the
du
time to answer
continent.
questions later, but given how short we
Je
had,
dois vous
I just
laisser le
wanted to
temps
give
pour
you some
répondre
key
aux
bullets on
questions,
the topic.
mais j'ai
Thank
voulu
you.
vous donner ces éléments
Thank you
saillants
so
au
much,
départ. Merci,
Seth,
merci
for
beaucoup.
setting the stage and
Merci
you
pour
know, great
vraiment nous
data there
donner
to
cette
actually
fondation
call
avec
us to
des
action.
données tellement
And I would like
importantes
to
qui
then
nous appellent
ask
à l'action.
Beth
Et je
Evans.
veux
Beth
demander
is a senior
Evans,
program manager
qui est
on
chargé du
meningitis at Gavi. So
programme
Beth, based
de
on
la
what Seth has
méningite
said,
à
what
Gavi.
are
Alors,
countries doing? Because
basé
of course,
sur ce
Gavi
qu'il
for
vient de
Africa,
présenter,
I keep
quels sont les
saying
pays?
that
Parce que Gavi
Gavi's
pour l'Afrique
business is
du
Africa and
Sud,
Africa's business is Gavi. It's
les
really
business, les affaires de
the
Gavi sont africaines et
vaccination
l'Afrique
partner
est
across
pour
the
le Gavi.
continent. And we are
Alors, parce
talking
que c'est un
about
partenariat à travers
vaccination
le
and first
continent et
step.
nous parlons de
So
la
what
vaccination comme la
is
première
going
étape.
on at country level
Alors, qu'est-ce qui se
from what
passe au niveau
Gavi
pays
knows and
à
is
partir de
partnering with
ce que
countries on?
le
Over to you, Beth.
Gavi, notre organisation,
Thank you so much, and thank you for inviting me to be part of this session with
Merci
so many
beaucoup de m'appeler
distinguished
pour faire
speakers
partie
and
de
so many
cette
attendees.
réunion et
As Seth mentioned, since the rollout
comme
of
il a
meningitis A
mentionné,
vaccines, the
depuis
serotype
qu'on
has been
a
virtually
lancé le
eliminated from the
vaccin de la
meningitis belt.
méningite
And Gavi have been
A,
supporting Men A
Gavi a
vaccines since 2010.
appuyé
Almost all
l'Europe a
countries
des
in the
vaccins
meningitis
depuis
belt
2010.
have conducted
Dans
mass
beaucoup de
preventative
pays où la
campaigns that's
méningite
targeting
sévit,
children from 9 months all the way up to
ciblons
people up
les
to
enfants de
29
9
years old
mois
with those
et
campaigns.
jusqu'à
And
29
15
ans.
Gavi-eligible countries
Et
have also introduced Men A
les
vaccine
pays
into their routine
éligibles ont reçu
immunization
des vaccins
programs.
dans leur programme
These numbers, this is an incredible
d'immunisation
achievement, and the
régulière.
fact that
Ça, c'est une
the A
réussite
serotype has essentially been eliminated and not seen
importante parce
as a
que
cause to epidemics since
on commence
2017
à
is really a
constater qu'il y a
testament to the
vraiment
efforts from
la
the partners
réduction
like Gavi,
importante
WHO,
de la
UNICEF, donors,
méningite
CSOs, but particularly the countries and the
et
communities who are
beaucoup des
driving these
organisations de la
immunization
société
programs
civile
in the
et
meningitis
autres
belt.
organisations comme l'OMS ont déjà fait des progrès
Again,
pour
as Seth
ce
highlighted,
travail. Encore,
other meningococcal strains
comme il a
continue to
mentionné,
cause devastating deaths, disability,
la
and
méningite
continue to
continue à
drive
causer
epidemics.
du
And we're seeing those
dégât
trends
et à causer beaucoup
in Gavi
d'handicap aux
eligible in
personnes qui
Africa.
guérissent de la méningite
With the
en
first
Afrique et dans d'autres
multivalent
pays du monde.
meningitis
Alors,
vaccine,
le
Gavi's board
vaccin est un
approved it back
projet
in
de plusieurs
2023
millions de
to
dollars
incorporate this into our support. And this year in June, we opened up the program. So that's allowing countries to apply to introduce the multivalent meningitis vaccine and for our high-risk countries to conduct mass preventative campaigns in populations up to 19 years old in line with the recent SAGE guidelines.
Pour voir comment
Now, I'm really
réduire
happy to share that last month,
Et je suis content de
Niger
vous
was the
dire
first
que
country
le
to
dernier
apply
mois,
and to be
le
approved by an
Niger
independent review
est le
committee.
premier pays
And that's
qui
going
a
to be to
accepté
conduct
d'utiliser ce
a
vaccin.
Men5 multivalent meningitis campaign, which will actually be integrated with typhoid, which is a great opportunity as well, just thinking about the burden sometimes that campaigns and disruption that they can cause. This integrated campaign, which is planned for next year, will be the first rollout of the multivalent meningitis vaccine funded by Gavi for preventative use. And we're really looking forward to seeing the impact there. We do continue to support outbreak response. There's a stockpile of around 7 million doses that's maintained at all times. Seth mentioned that was used for the first time in Nigeria, and also it has been used in Niger earlier this year. And then finally, I did just want to note that whilst we are a vaccine-based organisation, we do also have work on diagnostics and surveillance, and that, like you mentioned earlier, is key. And so that we are also supporting the availability and use of meningococcal diagnostic tests. And right now, these are not yet procured. We currently procure yellow fever and cholera tests for countries, but in the near future, the aim is to support diagnostics during Gavi 6.0 to facilitate strong surveillance and timely outbreak response. Thank you so much. I'm happy to answer any questions later on.
Oh, thank you. Thank you very much. Before I hand over to Edwin for the panel, I just have one question. So I know that there are several people here on this webinar from governments, and they're listening to you saying Nigeria has been approved. So what message would you have for country policymakers who are on this webinar from Africa, if any?
Particularly for the high-risk countries, Mali, Chad, Burkina Faso, Benin, Togo, Uganda, and Nigeria, this multivalent meningitis vaccine could have a real impact in terms of the public health benefits. There is, of course, the cost considerations, and I think sustainability and the fiscal space is important to consider. But if you have done successful Men-A programs and you're seeing continued meningitis, please do reach out. We can support you through the application process. WHO are also supporting countries with risk assessments to really understand burden. In some cases, it will be a subnational campaign that might be the best fit. In other cases, it may be, switching from the current Men-A vaccine and routine immunization to campaign. But I'm very happy to talk more to individual countries about what might make sense based on the epidemiology and based on other considerations around the broader, more holistic vaccine program, understanding that there are many priorities, but this is a real one, and we're very keen to support the impact here.
Thank you so much, Beth. Thank you very, very much, Beth, and thanks, Seth. And now I hand over to Edwin for a country conversation about what's going on. So over to you, Edwin.
Thank you, Dr. G. And Seth in his slide made the point that is important for people to remember, right? Is countries are the most critical and important partner in this particular challenge, in almost any public health challenge. So it's a great pleasure to have an esteemed panel of three individuals who are at the country level really making things happen. And I'll ask them to come on video if they're not yet, so that we can all see them. And I'll start with you, Dr. Fatima, given your role in Nigeria, Nigeria CDC on the surveillance side. In a lot of ways, understanding the shape and form of a disease is just as important, if not the most important, first step that a country needs to make so that it can mount the appropriate responses as needed. Could you talk us through the way Nigeria has been approaching meningitis and really beginning to put data and information that then can lead to appropriate responses? I see you've gone back off video, Dr. Fatima, but you're still on mute. So if you can come off mute, then we can hear you.
Yeah, so thank you so very much. As rightly said, Fatima Saleh is my name, the Director of Surveillance and Epidemiology, Nigeria Center for Disease Control and Prevention. Could you kindly recap the question, because I think I missed the initial bit of it.
No problem. Happy to. I know connectivity can be a bit of a challenge. I was saying, how has Nigeria approached the surveillance end of meningitis, knowing that the ability for a country or any population to understand the shape and form and dynamics of an issue like meningitis is the first critical step to being able to mount the relevant and needed responses?
Yeah, so let me start from the point of view of the fact that, as the first presenter highlighted, Nigeria is happy to repeatedly say it again and again that we had set the pace as a country. An unprecedented record of actually, being the first to really use the MEN5 vaccine, taking into consideration all the diverse serotypes, the A, the C's, the W's, the X, the Y's. So, but having said that, as a country, we believe is the data that will definitely guide any decision we take. And by so, we collaborate with all relevant key stakeholders. For instance, meningitis is a vaccine-preventable disease that we all know. There is no way the interventions around immunizations can be done, effectively without having this handshake with the surveillance data. And that handshake, we ensure that we have at least an estimated burden of the meningitis that we have as a country, so that we tailor, the immunization activities around that. Again, as a country, we know, we have the routine, we've institutionalized vaccination of meningitis, the pentavalent, and the other ones. And also, you also recall, I'm happy Gavi is here. During outbreaks, we also, strengthen our, response with campaigns, vaccination campaigns. That has to do with a formal request during emergencies, of course, to the ICG. So aside the routine immunization, which is guided by our data, definitely during emergencies, again, we also do, reactive vaccination campaign, just so to, step up our response to meningitis. Again, we do this, as I said, with surveillance data. And how have we been doing it to be able to get this right? That data gives us, an avenue to mount enhanced surveillance to ensure we keep watching and looking at which states, which LGAs, the subnational, are actually crossing the epidemic and the alert thresholds. Is that data, again, weekly monitoring of that data that could alert us as to which one is in the epidemic or in the alert threshold, so that we targeted some of these interventions, either deployments of RRTs, either countermeasures, and so more of those interventions, so that they are really targeted based on the enhanced data. And with the robust lab infrastructure that we have, thanks again to our partners, Gavi, WHO, CDC, and the rest, we're able to really detect these things, so that prompt management is mounted. So it's actually around data. You can't do these things without the data. And all what we do is actually trying to see that we strengthen this modalities of getting this data real time. You are aware we have our electronic IDSR that we use. That's the SOMAS platform. So that is what we are leveraging to actually get this data real time, to be able to do what we are doing as a country. And even though the domain 5 introduction was actually based on the data, it's because of the good utilization of data that we're able actually to roll that out. So yes, that's how we do it, but data actually is the main issue here that guide whatever we do as a country. So I want to pause now. I'm not sure if I'm able to answer your question.
No, that was fantastic. Thank you, Dr. Fatima, and we'll come back to you for additional conversation. I can hear you. Can you hear me? Did you lose me?
We can hear you.
Can you hear Edwin? Okay, good. Thank you.
Can you hear me okay now? Okay. I assume you can hear me. I'll shift to you, Dr. Samba, given your work at the Center for Vaccine Development in Mali, which is such a critical piece of both, kind of generating the next generation of vaccines, but also, hello? Can you hear me, Dr. Samba?
Very well, nice and clear.
Fantastic. Okay. So tell us about the work at the CVD.
I can't hear Edwin. I am not sure that I'm the only one, because I can't hear him. So something must have happened.
What happened is he's not on the translation channel. He's on the original language channel. That's what's happened. So you have to turn back on the original one to hear him.
Okay, so unmute the original audio to hear Edwin.
Yes,
Thanks, Seth,
you can
for
hear Edwin loud and clear.
101. Edwin, please proceed.
Yeah, I was worried that was the problem. It sounds like it's a technology issues. No, glad to be on.
A lot of people, Edwin, please let the people just notify. Please put off them, because I saw a lot of comments also saying you are inaudible from the group, the webinar itself. So just remove the, unmute the original audio. Sorry, Edwin, please proceed.
No problem. I hope others have been able to catch up, and the team, please send the instructions on the chat so that we can catch up on time. But the quick one is, if you chose a language, there's an option to unmute original audio. If you mute that or unmute that, then you can hear me as we're going through. So hopefully that works for everybody. But I was coming to you, Dr. Samba, on your work at the CVD, which is so critical in developing that next generation of vaccines, not just from an African, making sure it's responding to the challenges and issues on the continent, but just as importantly, that it is on the continent, given some of the challenges we saw around the COVID-19 vaccine. Could you tell us a bit more about how CVD has been on the forefront of advancing vaccines for meningitis and beyond?
Thank you very much, Mr. Edwin. I would like to thank the organizers, Amref and Gitenji's team, really putting us together around, this, as your name indicate, Africa Health. This is really, really a great day to have a dialogue around such a devastating public health issue. I don't know a single family in Africa in the belt without experiencing at least one case, and if yes, then at least one death, or at least one very irreversible disability. So Seth described those things right during his presentation. So it used to be really bad, but today, thank be to God, because of vaccines and vaccination, things are getting better. And as Dr. Fatima said it right, Professor Fatima said it right, data are key. What I would add into that, locally generated data, because usually people will just bring vaccines in our continent, in our countries, and they will bring this without actually no robust data to even convince doctors. We have seen this not only with meningitis, we have seen this with Ebola, we've seen this with COVID, and we continue to see it even now with Mpox. There is almost no data available. So I would really say that those locally generated data are very helpful. Number two, the fact that we are now developing vaccines in Africa. During COVID and Ebola, not presently COVID, we said we want to manufacture vaccine in Africa. That's helpful. But the actual development process started with really MVP project, meningitis vaccine project. And we set up robust surveillance system in Mali to generate locally data and be able to convince communities that we have these killing pathogens, including meningitis, and that we can do our own development process, partnering with northern institutions and universities and researchers, and have a win-win partnership and do this trial. That's how we started to work very closely with MVP, WHO, PAF, and also working very closely with Gavi when we start to get, and Seth was really a very good champion during that process, because he was just starting his CEO role at Gavi, and we were, kind of finishing this trial. So we did the very first, except the phase 1, we did all the phases for MEN-Afrivac, Men-Conjugate, Men-A, and also except phase 1 that we did at the University of Maryland Center for Vaccine Development under Prof. Karen Kotloff and Wilbur Chan, leadership. So we then did the phase 1 there, and then now we are doing all the phases in Bamako for this pentavalent vaccine. And thank be to God, it's working absolutely well, and it's helping. It's making life so easy. Last week, WHO was here with Gavi doing this risk assessment. The Minister of Health called me to come and present this trial essential data to them so they know. So when I said that, one of the questions, where did you do this trial? We said, we did all that here in Mali. People were really surprised. So we are learning that the more trial you do in Africa, in our continent, about the disease, the more development you do, the more surveillance you do, the more data and the more opportunity you will have to convince not only your communities, but actually your leaders to show that these are not things coming from outside. These are real data coming from here, and surveillance data could do the same. And then the other thing is we have to quickly be able to separate the sheep from the goats. I mean, show our leaders that when you say meninge, it's not all about Neisseria. We know there are other bacteria giving meninge, and they are also very powerful, like pneumococcus, for example, is one of them. Like HIP is another one, etc. So, and then if you talk about serotypes, people used to only know A. So now we have more than A. If you say W, people will only think W135. So this penta being developed locally in Africa by Africans, for Africans and with Africans, for me, this is a big opportunity for you guys to really talk about this, to celebrate this meningitis day for Africa, in Africa. And really, congratulations to you for thinking about this. And you got the right people. Prof. Berkeley is definitely one of the champion in our continent who can talk about this. Of course, Gavi and all of us here. And mentioning defeat meningitis for WHO is key. I'm co-chairing defeat meningitis with Prof. Brian Greenwood from the School of Hygiene and under Marie-Pierre Preciosi leadership, who also participated. She was leading with Mark Laforce, Prof. Mark Laforce, the MVP program and PAF. So really doing trials in Africa is fantastic. It's helped people to understand, because we do a lot of community meeting, a lot of community approaches. And thank you very much.
Yeah, I couldn't agree more. In a lot of ways, that's exactly the raison d'etre for ACSUM, and in many ways for Amref. It is those who are most proximate to the issue are the ones who have the best capability to solve the problem. And for too long, these were thought of as problems that sit in one place or one geography or one domain, and solutions are generated elsewhere. And that is no longer the case, that is no longer true. And we've run as far as we can, where people who are not of the place, from the place, trying to solve the problems, right? And so couldn't agree more with you, Prof. Samba, on those closing comments. Let me come to you, Professor.
I was supposed to speak French, and I totally
it happens when you get passionate about something. When you get passionate about something, it's the language that comes out, and that's totally fine. I hope colleagues who are listening in French, the interpretation is working well now. You've been able to figure out how to switch the channels on interpretation. Sorry for that technical issue, but hopefully you got the comments. Let me come to you, to Professor Eric, on this big switch that Niger is now doing in moving from, kind of the single strain to the penta vaccine. Tell us about what that process has been, how you're thinking about rolling that out nationwide, and what are some of the anticipated challenges that the people on the call should be thinking about, and ideally also leaning in to be able to support the solution of. Are you on, Prof. Eric, or did we lose you? I suspect he is not on, or if he's speaking, can any of the team confirm if he's on?
No, I don't see him. I'm trying to roam through the panelists, so he may have dropped. So as we check on him, you could proceed as we find out. Yeah, thanks. And then please, I'm hearing a lot of people saying, when they switch speakers, you can't hear. Just maybe you could just do a quick check on, I've asked everyone to say whether they have a challenge, then we'll help them. Just unmute the original audio. Make sure it's unmuted. Thank you. Over to you, Edwin. I'll let you know when the Prof is back.
Sawa. Well, let's come back to you, Seth, given the, you operated at 30,000 feet level, right? While you were heading Gavi, and your presentation was fantastic in terms of laying out the scene of the challenge ahead of us. If we go down a level deeper and then we're asking, what are the things countries need to do to be ready for this switch towards the Penta vaccine? From your perspective, what are some of those things that they need to start thinking about in advance?
Thanks, Edwin. And all I can really do is add on or reinforce what we've heard from other speakers and Fatima Samba, because the local data is critical, and it is about the vaccine's use in Africa. And the reason that's so important is, we're going to be using these vaccines in combinations with other vaccines, and you want the populations to know they've been tested, that they're safe, that we understand that they work for the diseases that we're seeing. And so I think that process, which, by the way, for me, is the right process for anything. Yep. But it's a little bit different when you have a vaccine that is being used globally, and there's lots and lots of data worldwide, and you can make a case that data then can be used here. But in this particular case, it's unusual. We don't really fully understand why the meningitis belt has this amount of disease, and therefore it really is a specific challenge in Africa, and therefore African researchers, African surveillance is absolutely critical to do that. The last thing I want to say, and we all know this is the elephant in the room, the anti-vax community has been strengthened after COVID. Yep. A lot of concerns, a lot of issues, there's a lot of conspiracy theories, and we're one world. Misinformation moves globally these days. And so the challenge, I think, is how we as a community in Africa have African spokespeople that can push back on that. And I suspect that this is actually going to get worse given some of the politics that are going on globally. So I think this is very critical. I know we have some NGOs on the call, and having those champions be there to answer questions and to reconfirm. And when there is misinformation, which there will be, having people like Professor Sambosao to say, we did these trials, here's actually what happened, don't listen to that stuff is really very important.
So if I can call on some of the people on the audience, and I don't know if they can be promoted to being panelists or if they can unmute. One would be Dr. Andre Bita Fudov, who's the Regional Control Officer for Meningitis at WHO Afro. Would love to get Afro's voice in exactly this question of countries being ready and making the switch to the Penta vaccine. What are some of the elements you're seeing in the conversations with countries from your level that would be important for stakeholders on this call to be aware of and start planning ahead for?
Thank you very much, and congratulations to organize this great event, this great webinar. Greetings to all the panelists, especially our co-chair of defeating meningitis. Yes, I would like to say that as Dr. Saleh was saying, Fatima was saying, Nigeria was the first country to introduce MEN5. It was to respond to meningitis outbreak caused by C. And also Nigeria caused by W and C. And almost 5 million people aged 1 to 25 have been vaccinated. And really 2 weeks after, they didn't record any cases of meningitis. So the first effect of these vaccines are very, 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 very great. And community participating, you have NITAC, the National Immunization Technical Advisor, that participate, and all the regulations bodies and all the partners, the government were very committed. So how to be reached? And as you know, Nigeria is the first country that will introduce MEN5 into routine immunization. So has WHO recommended that prior introducing MEN5, the country has to conduct a risk analysis, meningitis risk analysis, to really know the highest risk area, the moderate, the high, moderate, and the low risk area district. And then the highest risk district will be the one to conduct preventive campaigns for people aged 1 to 15. Right now, we have started in Nigeria. Nigeria conducted the risk analysis. Niger, Burkina Faso is conducting now. Last week it was Mali, and we were in Ghana 2 weeks ago. And then they have to discuss with NITAG. NITAG have to advise. NITAG is the National Immunization Technical Advisor Group.
Right.
Advising the Minister of Health on introducing these vaccines based on the evidence on the field and all what is happening, the first effect and others. After then, the countries has to submit his application to Gavi as Niger did. And then after few recommendations can be made, and then Gavi will approve. Right. And we know that we have introducing in routine immunization with co-financing, and also for the countries to organize this one. And then after the countries start to prepare all these campaigns and the suite, because right now 15 countries introduce Menafrivac, the first the meningitis vaccines. Then they will switch to MEN5. And as you know, this will be really an opportunity to provide a herd immunity. And based on the success of MEN-A that we had, no cases since 2015 after vaccinating more than over 400 million people. So we think that we can duplicate this success with all the commitment of all the partners and the countries. Thank you, over.
Thank you very much, Andre. Let me call on you, Rhoda, to speak about that critical question around vaccine acceptance and hesitancy, and the role of CSOs, given the Confederation of Meningitis Organizations, the incredible work you've been doing on the ground. Would love to also get your thoughts on exactly this question, is how do we get ahead of the challenge that we know is coming, and what are the kinds of things that countries, CSOs, and other stakeholders need to be aware of and need to be doing to get ahead of the issue?
Okay, good evening, everybody. Like you said, my name is Ms. Somorodi Roda. I'm glad to be in your midst. Talking about vaccine hesitancy, we've actually been facing that challenge and be talking much about it. Like I've said in other meetings, to enable us to be able to counter this issue, I think I want to say that more involvement of the civil society organizations, the faith-based organizations should be brought on board. Because right now, there is a lot of misconception around vaccine. Since the COVID era, there have been a lot of talk, a lot of negative talks around vaccine. So we'll be finding it difficult to counter this. But the only approach we are using is, like in Como, we talk about telling your story, where we have people who have had issue with certain ailments come to talk about it, like a survivor of meningitis, or somebody who had something like HPV, human papillomavirus, comes to talk about it. And when we use such people to address it, their story persuade others to like, oh, if it is like this, I think I really need this vaccine. So much of the work have to be with the civil society organization and more of the faith-based organization, because as you all know, over here in Africa, we're a very religious people, very, very religious. So we really need to work along with them to be able to counter the misconception or the myths around vaccine. Then on the area of meningitis, I think one area we may have issue is presently a lot of focus are more on the meningitis bed states. But if we accept to carry all states together, whether the meningitis bet or the non-meningitis bet is also going to help. I use Nigeria as a case study, and the state where I live is actually called a non-meningitis bet state. But right now, we are having a lot of inflows in interstate travel where those living in the meningitis-based states are moving into the non-meningitis-based state. And that is a threat, a future threat. And I've been advocating on that considering this particular point and other issues, other reasons like the climate change issue, there is needs for all stakeholders to begin to think of how we can address issue of meningitis, both at the non-meningitis-based state and at the meningitis-based state. You also asked me, what exactly are we doing in Como to address this? I've talked about the storytelling. Then we're also doing a lot of networking, media campaigns, social media mobilization to see how we can reach people to get them aware of it. We try to let people understand meningitis is something that over here in Africa is still very strange word. It's not yet known. Like the way we talk about HIV, we talk about malaria, we talk about tuberculosis, our people knows about it. Now COVID, our people know about it. The meningitis is not yet assimilated. Our people have not really come to terms to really understand what meningitis is. But though they've not known what it is, yet we have people that have epilepsy, yet they don't know how it's come. We have people that have the sequelae of maybe they've lost their hearing. We have people that have issue with coordination, and such issue are people attributed to spirituality. So this is why I keep saying that the civil society organization, the faith-based organization have a lot of role to play. Then we'll go to our government sites, like the Ministry of Health. I'm also trying to pay advocacy to them that there is needs for them to see how they can put into their budget the issue of care and support. Because most people that come down with the sequelae of meningitis, it is something that they find so difficult to be able to follow up with or to care of. So if the government can integrate a part of their budget for care and support for survivors or caregivers of meningitis, it's also going to help us. So the vaccine is good, but the awareness is also more important. So while we're talking about the vaccine, we should also talk about the awareness together. When our people get to understand that this is meningitis, this is how bad it can be, this is the sequelae, this is what can happen to somebody that survive it. And the challenge is not just on the survivor, it's also on the family members. So once our people get to understand this negative aspect of it, the vaccine will not be an issue to that extent, because our people have been taking vaccines for vaccine preventable disease until COVID came up. But I still strongly believe that when they get to understand it, they will take the vaccine. So this is what we have been doing, and that's what Como has also been promoting. Thank you so much.
Thank you very much, Rhoda. Dr. Fatima, I see your hand is up. I suspect you wanted to add something to Rhoda's comments.
Okay.
Sorry, I think I forgot to mention a key as part of the preparedness generally that we are doing around surveillance, enhancing surveillance. It's key to also hear here that case-based, actually, it's case-based surveillance is something that we find very instrumental in terms of response to meningitis and, of course, the lab investigation. But most importantly, our cross-border surveillance is something that we are heightening, especially around those communities, neighboring countries with high meningitis burden. So it's important I also remind the participants here on some of these things that we do. And again, I don't want to forget a key thing that we are currently doing as I speak, people are out there on the field. Genomic surveillance, meningitis genomic surveillance is something thanks to our partnership with Oxford and some colleagues in Abidjan, that's Cote d'Ivoire. Yes, that partnership. Yeah. So in 2 states currently, this is what is happening. So again, this totality of all of this tend to strengthen our surveillance system, and we feel that could provide further evidence for us to really, respond to meningitis. On what the last speaker says about community engagement and awareness generally, I believe trust is key. Generating demand for vaccination. And ensuring people, uptake this. It's not a one-off thing.
Yeah.
Trust is key. Then don't give up. It's a sustained, community engagement. And it has to be, multifaceted and culturally sensitive to people's, you understand. So these are things, I look at it as a multifaceted thing, and it has to be tailored to suit people's, cultural and other norms and context actually. So I needed to add that. Thank you.
That's such an important point. One of the things we speak about at Axum is social transformation only happens at the speed of trust, right? And so if you don't have trust, then things will not transform. And so it's such an important point to make. Let me come to you, Seth, quickly, and then I have one other question. I know we are short on time, but Seth, quickly, your hand is up.
Yeah, I just wanted to make a point for everybody, because a lot of the questions that are being asked by people is, what do we have to study? What do we have to know? And I think what's important to say is the meningitis A data I showed convinced the world that something needed to be done. So that shows the power of surveillance.
Right.
This shift now to other serotypes, we don't know if what's happening is those serotypes are replacing the ecological link that existed for meningitis now, and they're just going to take over, or is this a transitioning process that is going to constantly change and shift? And the reason it's important to do that is because we're in a changing time, we really need to be studying and having that surveillance and having people engaged, because we can't write where it's going to be 5 years from now. We have to all work together to follow it and do everything we can to prevent that going forward. So just to say that it's different than it was 20 years ago, I could have said, we got to go after meningitis and, that's it. But now it is a little bit different.
Yeah, and students of biology know ecological niches don't stay open for very long, right? And so
exactly.
It's unsurprising. One question to Emmanuel Mugisha of PATH, who I hope is still on the call, is there a view of what climate change does to the meningitis kind of belt? Does it expand? Does it shrink? Because then that has a meaningful impact both on the programming that needs to be done, the surveillance that needs to be done, the demand for vaccines that will exist. Emmanuel, do you have a view from where you sit at PATH?
Yeah, thanks so much, Edwin. I hope you can hear me, right?
Can hear you very well. Karibu.
Yeah, thanks so much for the question, and thanks to the panelists for all this information. So definitely meningitis has been a very serious issue, but as has been indicated, vaccines have actually helped quite a great deal. In Uganda as well, of course, as you know, there was an outbreak response in 2017, which also helped. Now, of course, bacteria, as you know, they are largely driven by the climate, whether it is drought, whether it is floods, whether it is, especially when it is floods, and more particularly for the bacteria. I mean, for some of them, it's the floods, and for some of them, it's the dry season, and that's what actually facilitates their movements. And as we know now, there's a lot of climate change in most of the areas. So areas which used to have stable climates, where it was, for example, wet, moderately wet or dry season, it's known, and it was quite well managed. But nowadays, we are seeing a lot of climate changes in almost all the places.
Yeah.
Very unpredictable weather events happening in most of the places. And these are actually changing even what we see as the meningitis belt, which used to be a little bit fixed.
Yeah.
To me, actually, it's changing, because Uganda never used to be in that belt. But as we saw meningitis cases actually increasing. So we may see more of these cases across most of the places in Africa, so to say, because of the climate changes. And so, whereas we talk largely of the climate of the meningitis belt, we should actually begin thinking ahead of the other areas as well that might actually be affected by meningitis. So when we talk of immunizations, we should be thinking ahead and think of larger than geographical locations.
Yeah.
There's also the population movements, as you know. People are moving quite a lot from point A to point B, more than usual, more than before. And so this facilitates also disease movements in all these areas. So I think as we look at the future, depending on the availability of the vaccines, we should be thinking of covering more populations rather than being restricted to only geographies, because we see climate changes in all places. and diseases appearing in almost all the other places where we used to have a stable climate.
And the major complication, and in some ways could be an opportunity, is as this spreads to other geographies, other continents, in some ways we have existing capability, understanding, expertise on the African continent that we can take to the rest of the world, and making sure that we hold that position and building that capability is true. But on the other side, competition for resources, right, for vaccines and other things increases, right? So it's not, it's not a boon. It could be, it becomes a complicated world very, very quickly with climate change. And so it's important for all of us to understand that and program appropriately. Let me pass over to Dr. G, because I think you had one question, and I know we only have 2 minutes to go, but I think you wanted to ask somebody one specific question. It's clearly a side. We need more time.
Yes, thank you. The question, and we have to wind down now. We were always afraid that 1 hour is too short, especially for such an important public health issue. And we must thank our panelists for actually being brief and providing so much information. But one of the things I wanted to ask Vinnie Smith from the Meningitis Research Foundation, as you work with Como and others, one of the key questions that we'll talk about is data. And part of that data is actually serosurveillance, because I think many countries, my own country, I was talking to my daughter who is a medical intern ahead of this webinar and I asked her, are you seeing meningitis cases in your hospital? She says, actually 3 out of every 10 pediatric admissions in her hospital, which is a level 5 government hospital, are meningitis. So it is still there. But then I asked, so do we know about, the serogroups? We don't, because we just do diagnosis. There's no much on serogroups, which will lead us to the conversation on the pentavalent. So, Vinnie, what is going on in this area supporting countries? Is there much interest on this serosurveillance? And then after that, we will close this. So if you could make your response like a minute, that would really appreciate it. 1.5 minutes, very generous. Vinnie? I can't hear Vinnie. Can you?
No, I can't either. Did we lose him?
No, I see him there. He's unmuted, but we can't hear. So that's unfortunate. Yeah. So I think we'll have to end it there then. Sorry, Vinnie. Maybe if you can, you could type on the chat. But colleagues, we want to respect your time. And we know there are a lot of questions. We've tried to answer some of them. Others have not been answered. We are going to have a communication to everyone who attended this. With that follow-up conversation, we may then put some response on some of the questions. The next thing is that there will be a similar webinar on malaria. Please keep your ears on the ground for that. We'll communicate to you. And the final thing is that these conversations are going to converge at AHIC 2025 in Kigali, March 2nd to 5th. We'll be working with our partners to ensure that face-to-face we can then enhance this with more policymakers, communities, private sector, and all the stakeholders that are involved. So from Edwin and I, from Amref Health Africa and Axum, we truly appreciate your time here. And please join us for those next conversations. A big thank you to all the speakers who've joined us. And from us, it is thank you to everyone who joined. And just to say as we close, personal story, I lost my nephew in 1985 to meningitis. And he died when he was about 4 years and died staying with me in my room. So this is personal for me. Thank you, everybody. And I hope the progress that we are achieving can actually be achieved for all.
Happy holidays, everybody. See you next year. Please take the time to rest. Mental well-being is important, and look forward to the next conversation.
And thank you to our moderators.
Bye-bye.
Thank you.
All right, bye-bye. Yeah, bye-bye. Bye-bye. Bye-bye, everyone.
Thank you. Bye, everyone.
Thank you.
Bye, everyone.